I'd like to invite up now Gemma. Gemma Pound, she's a senior physiotherapist at St Vincent's Hospital. She's coming to talk about the beyond survival functional outcomes after in-hospital cardiac arrest, which is the subject of her PhD. Thanks, Gemma.
Okay. So hopefully I can fill in some of the gaps that we've been talking about how these patients recover after having an in-hospital cardiac arrest. So a little bit of background. Over the last decade, we've seen increasing survival rates following in-hospital cardiac arrest. And despite the fact that we know there are important differences between in-hospital and out-of-hospital cardiac arrest populations, in studies these groups are often combined. And there are a few RCTs looking specifically at an in-hospital cardiac arrest population, and studies rarely report outcomes beyond hospital discharge. So therefore, little is known about the longer-term functional outcomes of these patients, and particularly with regards to health-related quality of life and the quality of survival. To characterise functional recovery after cardiac arrest, the American Heart Association recommends using multiple impairment and disability measures with longer-term endpoints. And this was further emphasised in recent updated resource guidelines, as well as the publication of the core outcome set in cardiac arrest, or the COSCA publication, at the end of 2018. So the aims of two of my papers from my PhD are to evaluate the functional outcomes of patients following in-hospital cardiac arrest at hospital discharge, to evaluate the functional outcomes and quality of life of in-hospital cardiac arrest survivors at both 6 and 12 months, and to describe the trajectory of recovery, and to identify associations with good neurological outcome at each of the different time points. As Daryl's talked about some of the methodology of ANZ code, I'll just briefly touch on some of the outcome measures that we collected at the different time points. At hospital discharge, we looked at survival, disability status using the modified Rankin scale. This is a global measure of disability and considered to be slightly more robust than the traditional CPC measurement, and is the recommended outcome measure that was mentioned in the COSCA guidelines. We also looked at patients' independence with their basic activities of daily living using the CATS ADL measure. For consenting survivors, a telephone interview was completed at 6 and 12 months by myself. And outcomes we collected were, again, survival status, disability, again using the modified Rankin scale, health-related quality of life using the Euroqual 5D-5L. We also looked at hospital readmission rates and also return to work. So as Daryl mentioned, we had around about a 40% survival to hospital discharge, which is higher than what's been reported previously in the literature. Of these 60 survivors, around 63% were independent with their basic ADLs at hospital discharge. So this includes things like feeding, toileting, washing, dressing, and transferring from bed to chair. Around 70% of survivors were considered to have a good neurological outcome, as per the modified Rankin score of 0 to 3. As you can see on the diagram there, that ranges from no symptoms to moderate disability, requiring some help, but able to walk without assistance. At 6 and 12-month follow-up, 80% of survivors consented to a follow-up interview. Of these, around 80% were still alive at 6 months, and around 70% were alive at 12 months. At 6 months, around 65% of patients had a good neurological outcome, and at 12 months, this was 62.5%, with the median modified Rankin score at 2 at each of the time points. So just to display this graphically as well, as you can see, there's a slight trend towards improvement to the lower end of the scale of the modified Rankin scale. But quite a few patients actually switched groups. So some that had a good outcome at hospital discharge subsequently deteriorated into the poor outcome group, and then some that were in the poor outcome group became good. Also, as you can see, more patients had passed away at 12 months. There was no significant difference between modified ranking scores at between 6 and 12 month time points. So health-related quality of life. So for those of you not familiar with the EQ5D 5L, 5D stands for 5 domains, including mobility, self-care, usual activities, pain, and anxiety and depression. And the 5L is 5 levels. So no problems, mild, moderate, severe, extreme, or unable to perform that activity. I know the writing's a little bit small, so the first bar are patients that reported no problems. The middle bar is patients that reported some problems, and the third bar for each of the domains is patients that reported severe or extreme problems for that activity. So a couple of interesting points. At 6 months, 2/3 of patients reported having problems performing their usual activities, and 1/3 of these reported severe problems or were unable to perform their usual activities. So this includes things that are very important for societal participation, such as leisure activities, working, family time, housework, things like that. And interestingly, half of patients reported that they had some level of pain. At 12 months, there was some improvement in problems with usual activities, with half of patients reporting some problems and around 1/5 of patients reporting severe problems or unable to perform their activities. But at 12 months, half of patients still reported pain. This could, I think, be potentially related to the high number of comorbidities that these patients have. So when you do the EQ5D, you end up with a 5-digit health status, which you can then put into a program that gives you an index score. So a score of 1 is considered to be perfect health. So as you can see, at 6 months, despite the issues that patients reported, the median index score was 0.73. And at 12 months, 0.76, which is pretty good. But as you can see from the interquartile range, it's very broad. You also ask patients to rate their health on a scale of 0 to 100, with 0 being the worst health and 100 being the best health that they can imagine on that particular day. And as you can see, again, the scores were pretty good. So 70 at 6 months and a median of 75 at 12 months. Although, as you could see from the graph previously, there was a trend towards improvement in index scores between 6 and 12 months, but this didn't reach significance, unfortunately. And the VAS scores, there was no significant difference. With regards to hospital readmissions, at 6 months, nearly 50% of patients had been readmitted to hospital in the preceding 6 months. And at 12 months, this was 1/3 of patients. With regards to return to work, because our median age was 71, we actually had quite a low proportion of patients who were working prior to their in-hospital arrest. So it was about 30%. So of the consenting survivors, this was actually only 14 patients. At 6 months, 5 of those had returned to work, with 3 of those returning back to their previous role and hours. Of the 8 patients who had not returned back to work, they all reported that this was due to their health. At 12 months, 6 patients had returned to work, 5 of which had returned to their previous role and hours. And again, the ones that hadn't returned were still having problems with their health as the reason they hadn't returned back to work. So the third aim was to identify the associations and independent predictors of good neurological outcome at each of the different time points. So for hospital discharge, younger age, shorter duration of CPR, and shorter duration of hospital admission prior to their arrest were all independent predictors of a good neurological outcome at hospital discharge. So just to build on what Darryl said, so looking at the extreme ends of the scale, so patients under the age of 50 so 55% of them had a good neurological outcome at hospital discharge, and those over the age of 80 had about 20% of them had a good neurological outcome at hospital discharge. For duration of CPR, as Darryl said, quite a large proportion of them had CPR for less than 2 minutes, and of those patients, over 70% had a good neurological outcome. But on the other end of the scale, those that had CPR for more than 10 minutes had around about 6 or 7% had a good neurological outcome. Duration of hospital admission prior to in-hospital cardiac arrest. Those patients who had an arrest on the first couple of days of admission, on day 0 or day 1, had the best chance of a good neurological outcome. And those patients who were in hospital for a week or more had around about 15% of them had a good neurological outcome. So when we look at independent predictors at 6 and 12 months, the only variable that was an independent predictor of good neurological outcome at these time points were shorter duration of hospital admission prior to the in-hospital cardiac arrest. So in summary, the majority of survivors had a good neurological outcome at each of the different time points, and health-related quality of life was relatively good, despite half of patients reporting problems with mobility, usual activities, pain, and anxiety and depression at 6 and 12 months. Hospital readmissions were common, particularly in the first 6 months post-arrest. Less than half of patients returned to work at 12 months. There was no significant improvement in disability or health-related quality of life between the 6 and 12-month follow-up interviews. Younger age, shorter duration of CPR, and shorter duration of hospital admission prior to in-hospital cardiac arrests were independent predictors of good neurological outcome at hospital discharge. But the only independent predictor of good neurological outcome at 6 and 12 months was a shorter duration of admission prior to arrest. And I'd just like to thank the ANZ Code Management Committee. That's it. Thank you.